Good afternoon. Thank you very much for being here today. We will officially call this meeting to order at 12:14 this afternoon. This is the Governance Committee. Obviously, Mr. Roger Fisher is usually sitting in his seat due to family. He is out today, and so I will try to conduct this. And so again, thank y'all very much for being here. First, I'm told there is no one here to address this committee, so we'll move to item number 3 on the agenda, which is the approval of the minutes. The April 25th minutes were provided to you previously. If there's any questions, we'd so address them. If not, we'd entertain a motion. I have a motion. Mr. Montgomery. I have a second, Mr. Zimmerman. All those in favor say aye. Thank you very much. Committee chair report. Seeing how I'm not the committee chair report, I did talk to Roger when he called. He said there was nothing really. He said you might want to check with Robert if there's anything, Robert. So is there anything you want to add at this point in time?
I spoke with Roger last night, and I think we're all in order. I think we could go straight forward with the meeting.
Super. That being said, we will move to item number 5. We'll have our reports. The first one is obviously our board education, and I think, Ron, you're going to come up and start us with that. Thank you so very, very much. Our Chief Compliance Officer, Mr. Skillens, welcome.
Good afternoon.
Noon.
Turn the mic on. All right.
Ron, let me ask a question.
Yes.
From a protocol standpoint. Dr. Kramer, are you in clinic right now? Well, I know you're here right now, but
I knew you had some color.
what I'm trying to figure out without inconveniencing, you're okay. All right.
Okay, you're talking about time.
Yeah,
Okay,
I saw the look in your eyes, and I
that's-
want to make sure. I thought y'all were coordinated, but I
Yes.
want to make sure.
He's not shorting your report, Ron. He's just saying this.
Just say, right, exactly. No,
Floor is all yours, Mr.
we're on sync. So what I'd like to start off with today, I always try to start off with just a brief refresher for the purposes of the board for key areas that you should be aware of. This is a reminder, similar to last month. I talked about the elements of an effective compliance program and kind of how JPS is structured in our compliance program. This one is kind of a little bit broader. This is called the 3 lines of defense, and it's a framework that's been out for several years now, and it's not just healthcare specific. It's across all industries, and it's a way of thinking about how the governance structures within organizations should be structured. And so what I'll do is I'll just kind of briefly outline that and then how it works within JPS. So and this kind of, if you're a sports fan, I kind of like, use football analogies. The first line of defense is the front line, is the employees at JPS. So the nurses, the physicians, the techs, the support staff, clinical and non-clinical, are all part of the first line of defense, and that's generally considered to be management. And so those would be the policies and procedures, and ensuring that policies and procedures are adhered to and are acted upon, internal controls, that they are followed and processes are in place. And so, obviously that is a simple statement to say, but that is very challenging when you get into individual processes and departments to manage effectively. That's the reason why we exist, is to help the organization with that. The second line, no, it's fine. The second line of defense is the risk management functions, and functions is plural. It's not just the functions that I'm responsible for, which would include enterprise risk management and compliance, but also many people don't forget that the governance function within the second line of defense also includes finance, for example. So, the finance group is responsible for the internal controls over financial reporting and ensuring that our books and records are according with generally accepted accounting principles, and we have good financial internal controls. And all of that is a part of the second line of defense of the organization, as is security. Of course, we have our police force that does physical security, but also IT security that's in David's shop. Obviously, risk management is not just the risk management from ERM, but also the risk, the quality risk, in those departments. And so, how it should be structured, and we're no one's perfect, and we're working on this every day, and this is a part of what compliance is designed to do, is to work with management to identify either gaps or soft spots in those internal controls, or either areas of policy that are misunderstood and are not adhered to fully, and help the organization through education and training and various other things. And so, and then of course, we have a responsibility to report to senior management and to the board. And then the third line of defense that you all know are aware is internal audit. And internal audit, as we've talked about, is designed to do an overall separate evaluations of the second line of defense in terms of ensuring that we have risk management processes in place, ensuring that what we say we're doing, we're actually doing, and then report to you all as board members, as the governing body, to ensure that that these areas of risk are being properly managed by management. And so, you know, obviously how we're structured, and I know we have some new board members, but how we're structured is we have, you know, that's the purpose of this committee, as a governance committee, is that I report to you all and to the full board on areas of risk management, sometimes in open and closed session, as does Michelle from an internal audit standpoint. Really it's not, and I really try to emphasize this. I know we spoke here recently to our ambassador group, and I use the analogy of you know, Andy Griffith, and you know, and that you have Barney Fife, who has the bullet, that usually the bullet's in his pocket, and he doesn't have it in his gun. And my analogy to them is that, well, you know, we're all in, to a certain degree, that bullet. You know, we're not planning to use the bullet, but we have to have it in case we need it. But at the same time, we need to be ever vigilant. And so I didn't mean to call everybody Barney Fife, but but I think that's how they took it. But the point in being is that we all have to be vigilant, and that we all have a responsibility for governance and oversight. And then, last but not least, those two blue bars on the far right are what you all as board members are aware of, the external audit firm. The external audit firm has a independent responsibility to audit the financial statements of the organization, and if there's any fraud that's detected that's not caught within these three lines of defense, to bring that forward to you as board members. I won't go into the story now, but when I was a part of Arthur Andersen years ago during the Enron scandal, that was a fiduciary responsibility that the firm did not take during that period of time. And so many folks that I knew lost their licenses, their CPA licenses, and others, because they failed the public and the board on that fiduciary responsibility. So it's a very, very serious thing. I know, having been in the auditing profession, it's something that the audit firms now are being highly regulated to adhere to. And then I don't need to remind you all about the various alphabet soup of regulators that regulate that regulate healthcare, from Joint Commission to CMS to DOJ to OCR, and so there's a lot of additional alphabets that we can name, but that is a purpose of us, along with General Counsel, in performing these oversight functions. So I know many of you know this. I just wanted to kind of set this as a groundwork, because in the future meetings I'm going to build upon this and kind of go down a little bit deeper in terms of specifics we're doing around the three lines. But I'm going to stop there and ask if there's any questions.
Any questions for Ron?
Okay. All right.
Go ahead.
Very good. Well, the next, from an ERM perspective, I want to call up Dr. Kramer, and as many of you know, we have these highlights. We have 11 enterprise risk management areas that were identified 3 years ago. And by the way, this 2019, now that we're at the 3-year mark, is a baseline year, so we need to reset the baseline for where we are with each of these 11, and then determine whether we need to add some, or in some cases put some of these in maintenance mode. I don't want to use the term take away, because that doesn't mean that these aren't important, that there are initiatives still being worked on and so forth. But to orient you to, you can go ahead and come on up. But to orient you to this chart, the little crescent graphic on the right is meant to be where we are from a maturity of this risk area, how we are in managing this risk area. Now you'll notice this, in this case, it doesn't have arrows in it. That was by intention, because we need to work with, in this case, Dr. Kramer in his new role and capacity in his team to reset the arrow and to reset the baseline as to where that team believes we are from a maturity standpoint. And then so upcoming meetings will have that for you. So I just asked Dr. Kramer to come and give an update on provider engagement.
Okay, so first, I apologize for showing up in scrubs, but since it is on the topic,
Looks appropriate to me.
well taken. I was in the spirit of physician engagement, though. It seemed only appropriate that I would be called to help with something unforeseen in the operating room. But I do want to introduce myself for any new board members, but also really to reintroduce myself because my role has changed in the last 3 to 4 months, and my title has changed. So as Chief Physician Engagement Officer, I'm not in an operational position. I'm more in an influence position, in cultural development position, really trying to create strategy and process that we can implement that can drive specifically physician engagement, but and I hate to use the term provider engagement because it's a term that when you're talking about engagement of all our clinical providers, from a respect perspective, whatever their degree is, whatever their training is, the first step is to make sure we recognize that because of the incredible pride that they carry for that. So we still use the generic term provider, but I'm making a deliberate effort to make sure that under that umbrella that we recognize it's our medical staff physicians, it's our advanced practice providers here, and our resident physicians, because from a survey perspective, they are all equal participants in how we evaluate that. So that is my exclusive focus, but I'm also still a practicing obstetrician gynecologist, and so that's very obvious, I think, today by the circumstances in terms of my arrival. But in looking at where we have been, I think that's important in setting the perspective of what this looks like in terms of a risk summary. If you go back to the survey data that I have, that I can access, is in 2013, our physician engagement, and I will say physician engagement, but that would include all of our clinical providers, was at the 4th percentile. Since then, we've sort of had an increase and a little bit of a plateau, and in our last survey, we were at the 24th percentile. That's clearly not where we want to be, and it's not going to be where we will be. But when talking about engagement for the physicians, you also have to talk about alignment as well, because the methodology and the reporting is a little bit different than employee engagement. They report on engagement and alignment. One of the reasons for that is you're doing a survey for individuals that may not be employees within the organization. And in our circumstance, we have data for acclaim, but we also have non-acclaim providers as well. Our alignment is considered a leading indicator of where we are going with engagement. So we are substantially better from the perspective of alignment. And so this past year, we were at the 52nd percentile. So that really does set a positive tone because you need that before you really are able to move the needle on engagement. Alignment from the physician perspective is that connection that their goals for their patients, for their perspective of healthcare is in alignment with what the healthcare organization is doing and achieving. The engagement questions really are focused on how they feel about the care that their patients receive in the facility or the organization, what their connection is in it, how long they plan to stay within that organization, and the critical one is whether they would choose that particular organization for the care of their own family and loved ones. And I will say, looking at the survey, that is probably one of the most challenging questions, is that we have physicians here that have a very high regard for the institution, but as we've struggled with the access issue, it makes it difficult for them to answer their willingness to allow their family to want to be treated here. So as the operational issues address those issues, we would expect that would also drive engagement. So in terms of looking at the strategies listed here, there is a cultural development perspective of this, there's a leadership development perspective, but there has to be the operational piece that falls behind that is there as well. And so if, in terms of how our executive team roles have been sort of redefined and changed, having Dr. Hochberg as a chief clinical officer helping drive process, helping drive the operational pieces of this so that they're coordinated with our strategies for the cultural development of our clinicians. We expect to see an increase in alignment, and ultimately, as those processes improve, to see the engagement go up as well. Because from the perspective of all of our practicing clinicians, it's that patient experience, how they take care of patients, how we remove the barriers in their ability to take care of the patients, that ultimately increases not just their job satisfaction, but their engagement within that organization. And so having a role such as myself to help message that and help with the executive messaging and transparency and communication piece should put us well positioned to make substantial improvements over the next few years. But in terms of the assignment of where we are, that is a little bit challenging because we're at a bit of a reset point with all of the roles in trying to determine where exactly we are. But increasingly, having a more robust, clearly defined strategy to present to you that is very specific towards our clinical engagement piece is what we would expect for you to increasingly hear over the next 3 to 4 months.
Is there a reason why?
Why we using stuff for European community?
Oh, so you say European community?
Is that EC?
Oh, you talking about the three lines of defense slide earlier? Well, that was the IIA, the Institute for Internal Auditors, adopted that framework to articulate the 3 lines of defense, and so that came out of that white paper. That's kind of adopted from an internal audit profession.
Okay. And they pretty much conform to our compliance here in the.
Oh, absolutely,
Okay.
absolutely.
That's what I just want to know.
Oh, okay, absolutely. Question for Dr. Kramer? Okay.
Thanks, Tim.
All right, thanks, Tim.
All right, thank you.
Appreciate that. Yeah. We next have an update from Dr. Hochberg on clinical quality. And I typically only have one of these areas at governance, but this one needed to be updated with the board before the end of June for some leapfrog measures that we're trying to hit. And so Dr. Hochberg was good enough to be here today.
Yes, I was good enough here to be here today. As many could see, it says Dr. Stevenson is the owner, and here at JPS, we manage up. And so Dr. Stevenson could not make it, and so I'm his designee, apparently. But it really is my pleasure to be in front of everybody here and to talk about clinical quality. As Dr. Kramer mentioned, there's been a lot of moving parts that have occurred over the last several months. And I think that the organization is very well poised to progress even further. Within a lot of those moving parts was obviously the installation of Dr. Stevenson as our Chief Quality Officer, and then in my role as the Chief Clinical Officer, overseeing that aspect amongst a number of initiatives. As Dr. Stevenson and I have worked over the last 2 to 3 months, there's enormous opportunities and there are risks within our quality and patient safety division when we look at hospital-acquired conditions, when we look at surgical site infections, even when we see our recent leapfrog score grade of a C, we recognize that there's significant amount of opportunity to improve upon our processes, how we approach quality, and most critically, in being proactive in how we approach and tackle the various issues that we've identified. As we've sat and gone through and looked at previous harm events that have occurred, we have definitely identified a number of areas and common themes that cut across the network, and those things relate to communication and handoff and deviation from standardized practices and workarounds, and most critically, we see things in escalation and situational awareness, and those are examples when somebody doesn't call a supervising attending or doesn't escalate it up to an attending level because they believe that they can handle it. And we want to get to a point in our practice here where it's okay to ask for help. We have begun a reorg of the quality division and the various committees and councils that report up through the Quality and Patient Safety Governance, which then reports up to the Board of Managers of the Quality Committee. Two of those committees have been tasked to really begin to look at the systemness of our standardized practices. The first thing that they will be looking at is in the handoff process, which is one of the areas that many healthcare institutions have identified as an area that is rife for potential error. Because the more that you hand off, you lose information. People forget to mention one thing, things get lost in translation. And so we want to ensure that no matter where the patient is going from, no matter who's communicating to who, that we've got a standardized and consistent practice of how that handoff occurs. Another committee that we have reorged a bit is in the Patient Safety Council, and that is really to understand and to identify where we have patient safety vulnerabilities and recommend those task forces to be formed to identify and build upon strategies in which to prevent those potential errors. And then when particular action plans go into effect, to hold accountability and compliance around those various action plans. When I look at this risk summary slide, for most of the things that are on here, from risks and mitigation, they are still absolutely correct, and there's still things that need to be worked on and are being actively worked on. When you look at the risk mitigation of the infection prevention team focusing on reducing healthcare-associated infections, one of the commonalities that we have identified is clearly in hand hygiene. And we still hover as an institution at around 90% in our hand hygiene rates. And if there's one thing that can reduce infections, it's cleaning one's hands. And we see variability by unit, we see variability by physicians, we see variability by other particular staff. This is an area that is a particular focus on Dr. Stevenson, and it is one thing that he will be driving home and meeting with individuals, but that is just a simple thing that we can do which will improve the quality and patient safety throughout our organization. And so if there's one thing that Dr. Stevens and I truly, deeply believe in, it is around transparency, it is around visibility, it is around communication and collaboration across the system to improve processes, protocols, and standardization, because it is when you get into deviance is when error begins to develop. And so that is where we are. That is our journey. It is an ongoing one. And even if you get to a state of zero harm, it is still always an ongoing journey. It's something that we can never lose sight of or rest on.
Quick question for you on the last one, inconsistent transition of care. Is that from the clinical, for the use of transition care, or is it the inconsistent in transition of, in the standard of practice?
So it's, it cuts across all. So transitions of care is going to be part of that sort of handoff of transition from ED to floor. It's handoff for the post-acute services and getting patients back into clinic and the proper linkage associated to it. It's a case management function. So it goes back to the point I made about understanding our utilization patterns for our patients, where we have high-risk patients, and how do we appropriately get them through the system in a safe and effective way that's not just high quality, but also cost-effective. And so if you look at our connection patient population, transition of care incorporates developing the infrastructure to really manage them on a almost as if we were a payer in some fashion. So we understand exactly what our cost is, what our quality is, how to build a virtual type of environment for them.
Is this also tackle the patient compliance portion of it also as well?
Correct.
Any other questions?
Dr. Stevenson?
I won't make any Barney Fife jokes either.
That's right. And you made a great designee.
Oh, thank you. I will let Dr. Stevenson know.
I'm serving the same thing today, Michael, I understand that.
Yes, we all have a burden to bear.
I agree. Anyway, thank you very much, Michael. Ron, go ahead, I'm sorry. That sounds great. Thank you very much. No other questions at this stage. Go right ahead, Ron.
I'm going to ask Michelle Atkins to come up, go ahead and come up as this time as well. As you know, what I like to start out with is what's happening in the industry that's compliance related from an enforcement action standpoint. And so a couple of things. The reason why I picked both of these is they both deal with the Medicaid population, one here in Texas and one in New York. And they both deal with the patients that we serve in terms of the vulnerable population. So in the first case, the Texas Attorney General, Ken Paxton, and their team had a indictment brought against Xerox Corporation and several of its former subsidiaries for Medicaid-related kickbacks and improper use and improper claims to the Texas Medicaid program going back to 2004 to 2012. And essentially, what happened here is that the state had hired Xerox and some of its subsidiaries to do prior authorization requests for certain orthodontic services for children. And certain of those services were not qualified Medicaid services, particularly as it relates to braces and certain other orthodontic services. But they were kind of rubber stamped these because of the payments and claims that they had made to the Texas Medicaid program. And over the course of that several-year time frame, it was determined that those were all illegitimate claims. And so Xerox was fined a penalty of the $236 million, along with its former subsidiaries, mainly for abusing the Texas Medicaid program and that it was designed to be a control around. So that was the first case. The second case, similarly, it's not in Texas and New York, but it's even, if you could even use this term, more egregious, because what was happening here is that where it says the New York AG announces conviction of 3 quarter-house directors. So 3 quarter-house, if you're familiar with the term halfway house, where you have prisoners leaving prison, trying to reintegrate into society. And so this was a 3 quarter-house in terms of the amount of time that they spent in these facilities. And they also, these 3 quarter-houses also serve the homeless population as well. In the New York State, particularly in the Bronx and Brooklyn areas of New York. And basically what was happening is that the administrators for these facilities were essentially submitting false claims to New York State Medicaid for services that were not rendered to them, medical services that were not rendered. They were just submitting, they were getting their Social Security numbers and all the information. They were submitting false claims, and they were inducing homeless and these prisoners to come and stay at these facilities for the purpose of billing Medicaid. So there were certain individuals that were indicted for this fraud. It took several years to identify, and they were forced to pay $2.4 million. The individual administrators were forced to pay $2.4 million in this particular case, and it amounted to about $2 million, a little more, $2 to $3 million in fraudulent claims to Medicaid. So, again, one of the things that we try to focus on here is not to just highlight things that happen bad at other places, but also, the importance of the integrity of what we do in terms of looking at, when we talk about the billing and coding reviews that we do for Medicare, Medicaid. This is one of the reasons why we look at it so closely, and that we're in the spotlight. We want to make sure we do everything properly. So, is there any questions about either of those cases?
Ron, on the first one, when you talk about Xerox, you talk about the TMHP division, the Medicaid Fiscal
Yes.
Agency,
Mhm.
the ACS, the old ACS.
That's right. Yeah, yeah. So before we go on to the next slide, I did want to announce that I've had Michelle Atkins has expanded her responsibilities and has been promoted to Executive Director of Compliance and Internal Audit, and will be working with me in a greater capacity. So I look forward to that. I just wanted to announce that to the board as well. Yeah.
Congratulations.
Thank you very much. now we'll get into riveting material. The first compliance update we have is we give you a periodic pulse check on where we stand with the audits you approved last August. And this is the compliance audit section. Oops, sorry. This is the compliance audit section. Audits or probes. Now, probes are technically audits. They're just 10 or less. And what we typically do is we expect to have 0 errors on those 10. And if we do, we leave it alone and we move on. If we have any errors in the 10, we expand our sample. And sometimes what we might do is put that on a plan for next year, or actually go into and expand and move into an actual audit for your information. So we've completed 5, and it's necessary at this time for us to go in and advise the board that we have 2 planned audits that we need to defer to 2020. You see those in the box. The first one, we really just need some more we need some more resources on that, and that costs money. The second one is evaluation and management leveling. And there's a district project that was underway, and we felt like that was an opportunity for us to just get in the way and interfere with what the organization is doing, so we are going to defer that to 2020. The last 4 audits are actually underway. And so 3 of them are probes, and business associate agreement will be coming back to this board, the results of that. Any questions on the audit status update? The next slide, the purpose.
I guess one point I would make. On the previous slide, these are all audits or probe reviews that will be reported to the governance committee. As you know, every year we have this group to approve our compliance work plan, and it includes a number of activities outside of these audits and probes that are just not listed on this slide. I just wanted to make you aware of that.
Are you looking at home health also as well, beside DME?
Say
I'm
that again.
sorry?
Are you looking at home health beside DME, or just DME only?
In this space, yes, sir. So as Ron said, we do a little more than just audits and compliance. And one of the things that you may not be aware of is the government maintains a database of people who have been barred from doing business with the government and federal healthcare programs. And those 3 databases are LEIE, OIG, and SAM. And, they keep record of folks that would cause us a lot of problems. We would be subject to civil monetary penalties if we were allow these folks to do business here at JPS. And so one of the things that compliance does every single month is we gather up the workforce, all the workforce members. That includes our providers, our company 600 folks, all of our vendors as well that we've paid in the last, I believe, 4 years. And we run a search every single month through those 3 databases. Thankfully, we have a vendor who helps us do that and makes it rather easy for us. About 2.5%, as you can see, about 7,000 out of the 283 actually fell out as a potential match. And so what we have to do at that point, the vendor makes it pretty easy, but we just have to do a few clicks through their portal to verify whether or not that person is the same individual. And so over the last year, from April to March, we did not have any excluded individuals that we either hired or have done business with.
Are these physicians, nurses, all kinds of?
Everybody. Everybody. And, one of the reasons you can be disbarred, it could be for various reasons: felonies, license suspensions, healthcare fraud, controlled substance abuse, some misdemeanors, patient neglect, things like that. So there's any number of reasons that you could hit this list.
So for example, in the enforcement actions that I mentioned, it's likely that any providers or employees involved in either of those enforcement actions would be now on the excluded sanctions list and would be barred from participating in Medicaid or Medicare programs. If they're a physician, they can still practice medicine if they have a valid license, but they will not be able to serve Medicare or government patients, rather.
Okay.
And that may also get them under the contractual department, not just the government's department.
So the other thing that we used to do in compliance is we used to give you these colorful dashboards of our hotline that used to be loaded to the portal. We are still trying to hit the reset button on those, what are we gonna measure and how we're gonna measure it. So what I would like to do today is, since we haven't had any reports on the hotline in recent past, I wanted to give you a snapshot of the majority of our hotline reports are related to privacy uses or disclosures. 70% of those in April actually were. We had 61 total privacy reports in 6 months. 37 of those actually were substantiated, or 60% were substantiated. And you can see the outcomes that we had. Training and education, that number up there should be 54, not 60%, by the way, for training and education resolution. The disciplinary action means that we had to involve HR, and there was some sort of write-up, and then of course you can see we have 2 in progress, and then we had 1 termination. One of the things I was curious about is, why do we have use and disclosure separate? I mean, what really makes the difference? And through our research, a use, per the HIPAA rule, the definition of a use typically means there was something that went wrong within the organization, but the information didn't leave the organization. A disclosure typically means it went outside of the organization, and it could be a little bit more severe, and we may not know what happened with that information. So that is why we make those distinctions. Any questions on that? And, oh, I did have one more for compliance, I'm sorry. So as a result of the privacy, the highlighted privacy exposure, what we've decided to do is put a repeat focus and strategy around our patient privacy monitoring, education, and auditing. And so what I have on this screen is bolded things that are relatively new to our program with regard to privacy. We have a new privacy official. She is certified in privacy. She's also an attorney.
From Texas A&M.
Texas A&M, and
You got a good one.
and so we've always done newsletters, but again, on the bold side, what we have not done in compliance is had a really strong presence during the new employee orientation. And so we're gonna focus, we're revamping that entire deck, and we're gonna spend about 80 to 90% of that time really honing in on patient privacy. We're also gonna look at our CBLs, the annual computer-based learning, and focus on modifying some of those courses and actually highlighting the key questions that we really want folks to know. We've already added or revised a procedure for clarity on privacy, and one of that actually deals with accessing your own medical record, because we still see that happening. Instead of using MyChart, people are going through Epic because they have that ability, it's convenient, but that is actually not authorized here at JPS. One thing that's not on there in terms of training and education is we're also creating a frequently asked question, and we're gonna put that on our website, because we do get a lot of phone calls and emails in compliance, various topics, but we're keeping track of that. HIPAA privacy site assessments, again, I'm gonna have the privacy official go to the sites, provide education during departmental meetings, make it a Q&A. Maze Analytics, that's the software that you approved, I don't know, a couple of years ago, for us to easily access or easily monitor proactively the inappropriate accesses. I want to skip down to break the glass for employee patients. The compliance committee, executive compliance committee, last month approved that a break the glass, which is a sort of an extra layer of security, if you will. Before you enter a patient's record, a pop-up will come up and say, do you know you're going to break the glass? Why do you want to enter this record? And they'll have to put a comment. And so it just helps to add that little extra security. I know some employees may be a little, gun shy, if you will, of having services here because of their, the ability to get in and out of that record. So that's been a challenge.
Yeah, and we believe that this will be a huge employee satisfier, and I know PIA is in full support from an HR standpoint, because, this whole issue of, working here, and then you have a medical concern and you get treated here, and then you have employees that want to know why you're here and what you're doing and that type of thing. It causes a pause to those, folks that are, kind of nosy and curious, that, you have to actually break the glass, and it will be tracked.
They will know.
Right.
Yeah. Yeah. And then business associate agreement reviews. So believe it or not, the BAA, the requirement for BAA actually stems from the HIPAA privacy rule. And so first, we're going to confirm the existence and making sure that we, anyone that is in contact with PHI, we actually have a BAA for and on, they have signed. Subcontractors, the same thing. We're going to assess the security posture of our vendors and making sure that we've actually run them through the BAA process. And then, obviously, our business associates lose people, just like we do. They terminate. How quickly is their access being decommissioned? And then, of course, minimum necessary. Are we making sure that if we give someone access to our PHI, is it on in terms of minimum necessary? So-
On the BAAs, we use our own paper, right? For all our vendors, they're required to sign our BAA. Okay.
Yeah, I mean, some of them have their own, but it has to go through legal review in order for us to, but typically 95, 99% go through the approved BAA that we have here. The one thing I'll add before she moves off of that is it's not under our purview, but what we work hand in hand with IT on the security side of the house, and so we also have a new, what do you call it? Chief Information Security Officer, who's also happens to be from A&M, and right. Right, that's right. But his name is Mike Russo, and Mike was the former CISO for Texas A&M in College Station, and worked with the whole system there. So both Mike and Sarah on the privacy side will be working hand in hand on both the privacy and the security side.
Any further questions of compliance? We can move directly to a real quick update for internal audit. Likewise, we like to have a touch point of our progress for the audits on the plan and advise you of any changes that we have. You can see that we have 4 here before you. This last one is an advisory project, and many of you may know that advisory projects differ from audits in that it gives management an opportunity to request our advice or our assistance to proactively address any issues that they might have. And that report does not come to the board. That's why it says NA. We did have an ongoing professional practice evaluation that was approved last year, but that has been deferred with the recent changes in our medical staff in that specific space. But what we've done in internal audit instead is substituted 2 other advisory projects, as you can see here. And then in August, we will ask you to take a look at and approve our next year's plan for 2020 internal audit plan. Any questions on this side? That is all we have, I think, for open session.
Michelle, thank you very much. Ron?
Okay, we want to convene closed session? Okay.
Do we have closed?
I was going to ask you, do you need any closed session?
Yes, we do.
You do?
Yes.
Just want to make sure.
All right. Then if there's no other, this time we will take about a 3-minute recess and reconvene at 1 o'clock in closed session. Yes, I'm staying in this room. We're in. We will now reconvene in open session at 1:27. Is there any other business to come before the governance committee today? There being none, thank you for your attendance. We stand adjourned. Thank you.